Hi, I'm Jesse Kane, an interventional cardiologist at the University of Vermont. I'm going to be talking about the NHancer dual lumen microcatheter and its use in CTO PCI. Basically, a case where we use this to manage a dissection and resolve some ambiguity at a bifurcation in a right coronary artery. So the case presentation, basically a 67-year-old man with hypertension, hyperlipidemia, and an RCA CTO presented for PCI in the setting of medically refractory angina. He'd been on maximally tolerated doses of beta blockers, calcium channel blockers, and long-acting nitros, and echocardiogram showed preserved EF without significant regional wall motion abnormalities or hypokinesis in the inferolateral walls. He also did not have any significant valvular heart disease. What you can see is the initial dual injection angiography for our CTO setup. You can see that there is a prox to mid RCA CTO, and that is being supplied by some left to right collaterals, predominantly from a very tortuous epicardial off the circumflex. This made a retrograde approach very challenging and with limited options. Antegrade, there was some ambiguity at the proximal cap, and likely not a successful antegrade wire case either. So the main strategy was basically a antegrade dissection re-entry technique, and here you can see our Stingray balloon with a stiff penetrating wire that was advanced into the RPL. However, it's unclear exactly, as you can see from this angiography, where the re-entry occurred, and there might have been some subintimal tracking before it re-entered into the RPL, even in the distal RCA. This wire was then exchanged for a workhorse wire in the RPL, and retrograde angiography did show that there was potentially some dissection and compromised flow into the RPDA right at that bifurcation. So this isn't just a case where you can wire both branches. There's extensive dissection potentially in that prox to mid RCA now and into the distal segment. And so the two challenges are, one is managing dissection, and two is how to get a wire correctly and safely into the RPDA to protect both branches of the CTO. This is where we used our dual lumen microcatheter, our NHancer. You can see that the catheter is placed over our workhorse wire in the RPL, and then I use another workhorse wire to basically get into the RPDA. The dual lumen microcatheter, the NHancer, is placed distal to the dissection flap entry point, and this helps us confirm, based on both wire behavior and position of the dual lumen microcatheter, that we are in fact in true lumen, and we're able to protect both branches. And then after 3 overlapping stents were placed, you can still see some dissection in the distal vessel, but we have good TIMI3 flow now in both the RPL and RPDA branches, and we've covered the flap, and so in order to avoid bifurcation stenting and even more stents, I elected to accept this result and treat the patient as he feels based on symptoms. After 3 months, though, he's been doing very well. He's had resolution of his angina and has been able to resume his activities. So in conclusion, the NHancer dual lumen catheter is a valuable tool to help place a second wire in a segment of a dissected vessel to confirm true lumen placement. It's excellent when we're trying to resolve ambiguity at bifurcations, and it also is very valuable when we're trying to confirm that we've placed a wire in the same plane as the wire that we used to cross the occluded segment in our CTO cases. Thank you very much.